being able to wake up and not feel like you've completely lost, both of your breasts is a big deal, right? It's a big deal for self-esteem, for preservation of anatomy, all of those things. And cancer is already such a difficult journey that anything we can give these patients to maintain their identity and their sense of self as they go through it, I think is very empowering for patients.
Welcome to Baptist Health Talk, a podcast on all things healthcare, powered by Baptist Health South Florida, your trusted source for healthcare prevention and wellness.
Hi, everyone. I'm your host, Johanna Gomez, and welcome back to Baptist Health Talk, the show where we break down your most searched questions on health and wellness. Today's episode is a little different and a very personal one for me. At just 37 years old, I was diagnosed with triple-negative breast cancer, and suddenly I had to make some life-changing decisions about my body and health. Do I go flat? Do I choose reconstruction, implants? Like so many women facing this diagnosis, I had options, but I also had to make a really big choice. So what are those options and what do they really look like? That's what we're diving into today. To help us talk through this is Dr. David Mattos, a plastic and reconstructive surgeon at Baptist Health. Dr. Mattos, is great having you here. There's some things in life that it just takes you back, and that is that one thing for me as well. 2017, I was diagnosed in February. My life obviously flipped upside down, as you can imagine, that you see so many patients going through the same thing. And I had to start chemotherapy. I had to go through 17 rounds. So I had a little bit of time to think about the reconstruction part when it came to my journey. But not that much. It came pretty quick. So let's just talk for anyone that's watching right now. What are those options?
You mean for general reconstruction?
Correct. For general reconstruction, when it comes to implants, whether you go flat, double mastectomy, a lumpectomy.
Sure. So I think the first thing we have to step back and say, and first of all, thank you for sharing your story. Obviously, it's a personal story, and a lot of patients go through it. So it's helpful for other people to hear the story. The first thing I want to distinguish is when we talk about reconstruction here, we're specifically talking about mastectomy reconstruction, which means the entire breast is taken out. We as plastic surgeons are also involved in lumpectomy reconstruction, which means which is essentially a partial mastectomy. And that's a completely different conversation for how that goes about. But for the purposes of mastectomy, we generally speaking have three big picture options, right? One of the options is basically not having a reconstruction, meaning we're not taking tissue from anywhere else and we're not using an implant, okay? That's often called either an aesthetic flat closure or just going flat, etc. Okay. Then the other two big picture options for people who do want to have or preserve a breast mount is you either have to use your own tissue or you have to use an implant-based reconstruction. Okay, those are the big picture reconstructions. In our practice, most commonly what we do is a breast implant reconstruction, which means we use an implant, typically a silicone implant, and we pick something that goes, same shape based on your shape and based on your breast width and your own anatomy, and we individualize it to you so that we can preserve and maintain something that looks like a breast and helps you with, your self-esteem, recovery, and we try to walk you through that process, which is again, we are one member of the team of many who are taking care of you for breast cancer reconstruction.
Right. And then there's lumpectomy, which if you can just describe it.
So lumpectomy basically just means that instead of taking out the whole breast, they're taking out a portion of your breast. But remember, the breast surgeon doesn't get to pick which portion they take out. They pick whatever is affected by the cancer, right? So whatever is affected by the cancer has to come out. And then we, as the plastic surgeon, do what's called an oncoplastic reconstruction, where we basically use the remaining breast tissue on that side to try to reform the breast shape in its best way of possible without leaving an indent or another, a scar somewhere else on the breast.
But is that something that you have to make the decision right there at that moment during surgery, or do you kind of map it out prior?
In our minds, we map it out prior, but you have to choose to have a plastic surgeon available to help with your reconstruction at the time of surgery. So that's something that we plan ahead of surgery. And then if you want to have a plastic surgeon available for your lumpectomy and oncoplastic reconstruction, then we can coordinate that for the surgery itself.
I've also heard of some women having a procedure called DIEP flap. Can you explain that? I think it's a little bit more technical and a little bit, I don't want to say invasive, but it's a little more difficult.
So it certainly is both more technical and more invasive. A DIEP flap or a DIEP flap, which is the other name that a lot of people give it, is a flap of we use your abdominal tissue, okay? And we have to take out the abdomen, or like the abdominal wall tissue, skin and fat, and often a bit of muscle in order to be able to take out the arteries and the veins that go all the way into this tissue. And then with that artery and vein, we can hook it up into your chest. and allow that to be formed into a breast mound. But again, because it comes from the donor site, which is the abdomen, it does have a donor site, meaning there's another area that is essentially damaged in this process. And again, in theory, a DIEP flap is a perforator flap, which means that we dissect through the muscle and try to preserve the muscle.
Right.
But it's hard to perfectly do that without at least, injuring the muscle somewhat. And specifically, we're talking about your six-pack muscles.
Okay.
So it does have a donor site. It can, in theory, cause some weakness and other things we think about. So certainly longer procedure, but the benefit of that is that you don't have to use any implant if you're really trying to avoid an implant for reconstruction.
But not everyone is a candidate for that, correct?
Not everybody is a candidate. It really depends on both how much abdominal tissue you have to work with, as well as how big the breast is or the breast mound is that you're trying to preserve or maintain. And so they have to match for that to work.
You mentioned the abs, but is there another site of your body, part of your body that could be a donor site?
So you can, but those are not called DIEP flaps. That's we call that autologous flap, meaning using your own tissue.
Okay.
There are other ones, such as you can take tissue from the buttock, you can take tissue from the inner thigh, etc. Those are less common because they're much more difficult procedures and often much longer procedures. So we typically don't use that as a first-line reconstruction if you're undergoing reconstruction with your own tissue. Okay,
so like I mentioned earlier, I had chemo first. Right. So I went through my first 17 rounds of chemo and then I had to prep for surgery. Is that the case for everyone? And I'm just going to use an example as someone who's diagnosed with triple-negative breast cancer. Sure. Do they go through chemo first and then they go through surgery? Or is it just that was my case?
That was your case. It's very different for every patient. The patients who typically, from a big picture standpoint, undergo chemo first are those patients that the medical oncologists and the breast surgeons feel like are going to have a better surgical outcome if we're able to treat the cancer first with chemo, ideally to reduce the size of the tumor so that we then can take it out more successfully from a surgical standpoint. But typically, if the tumor is small enough, ahead of time, we typically will go in surgically first, right? For a lot of scenarios.
Got it. Okay, so I actually had a tumor right by my left nipple.
Okay.
So it was very weird because I couldn't get a straight answer if I could have done a nipple-sparing double mastectomy. Yeah. So for those that are not aware what a nipple-sparing double mastectomy is, can you explain that to them? And I know it's something that's very personal to a lot of women. It was something that was important for me. I actually ended up keeping my nipples, but it was a very last minute wake up and see if I have them or not.
Right.
Yeah.
So nipple-sparing mastectomy what it basically means is that you're able to do a mastectomy without taking any of the skin of the nipple or the areola, right? You make an incision elsewhere, sometimes around the areola, sometimes elsewhere, such as below the breast, what we call the inframammary fold. And basically, you preserve the entire breast mount. Okay, so you're trying to preserve the native nipple. However, as you say, there's basically two big picture criteria. And the most important one first is, are you safe to keep the nipple from a cancer standpoint? And that kind of depends, again, on the size of the tumor, how close it is to the nipple, et cetera. And so that's a conversation you first have with your surgical oncologist or your breast surgeon. And if they tell us that you're okay to keep the nipple, then we assess the patient from an anatomical standpoint, meaning we look at the nipple position on the breast mound before the mastectomy at the time of the consult, and we say, okay, is this something that we can preserve? Patients who have the nipple position much further down than the ideal position, it's harder to preserve because it limits our options more. Really, the ideal candidates are patients who have the nipples close to where they want them to be after the surgery.
So I'm a little bit farther removed from 2017 when I went through this. And I think at that time, nipple sparing, I don't want to say it was fairly new. It wasn't, not a lot of people were talking about it as much. Has that changed now?
I think, again, it's something that we're talking about more. Like anything else in the world of surgery, it becomes gradual. It gradually becomes something that is more commonplace to be offered elsewhere. At the Miami Cancer Institute, we certainly offer nipple-sparing mastectomy to a lot of our patients. And even when I assess my patients in my own consultation, I try to assess even the ones that I think are marginal, meaning they're okay from a cancer standpoint, but maybe in the former world, they weren't perfect from an anatomical standpoint. I ask myself, can I somehow get the nipple into position enough that we can still make this a nipple-sparing mastectomy?
Well, I will say thank you for doing that, because I will tell you one of the things that you deal with is the emotional of like looking at yourself and saying, I do not look the same. And I know, once again, I will say this is a very personal decision for everyone, whether they want to keep their nipples or not. But there are also options when it comes to tattoos, which is a great thing that has also advanced a lot throughout the years.
Yeah. I think the biggest advancement, to be honest, in terms of nipple reconstruction and how great they can look are 3D tattoos. So there's a bunch of tattoo artists throughout the country who have really honed in and developed the niche of doing 3D nipple reconstruction, which means that on a flat area of skin, they draw a nipple that looks like it's projecting, but it's really completely flat.
And it looks really good.
They can really be quite impressive when you look at them. So that's an option that is really great for a lot of our patients who may otherwise not be a candidate for a nipple reconstruction. But still, I think there are a lot of our patients who are candidates for, again, if we don't do a nipple-sparing mastectomy and they have to go what's called a skin-sparing, which means we take the nipple, but we preserve the rest of the skin as much as possible. For those patients, after they finish the reconstruction, we try to do a nipple reconstruction. And that often involves raising a little bit of tissue at the location where the nipple would be, and then eventually doing tattoo around that to give you the color of an areola and the nipple would normally have.
Yeah, thanks for science, right? It really does help us kind of like move past that journey wherever we are. This seems like a silly question, but it is one of the most looked up questions when it comes to having reconstructive surgery. A lot of women think, well, is it like a C-section? Is it like a surgery that I have had in the past? What's the best way, as you're the expert, that you could describe this? Because there are a lot of nerves that go into this surgery.
Specifically, describe what the actual reconstruction implant?
Would you compare it to a C-section? Would you compare it? And I know they're obviously two different surgeries, but the outcome, the recovery,
I would say, I think the biggest misconception, at least that I see in my practice, is not so much a C-section, but a lot of patients who are coming in getting breast reconstruction after mastectomy, especially with implants, think that they're getting like a breast augmentation surgery. And it is completely different, right? A patient who undergoes a breast augmentation surgery doesn't remove any of their breast tissue. They're basically augmenting it with an implant, but they still have all of the native tissue, all the covering of that tissue, the support of that tissue, et cetera. Reconstruction, you're basically trying to build a complete breast from nothing but skin and fat that remains. Everything else, the entire breast has been evacuated out. Right. And so everything from the size of the implants that we use to the type of projection that we use to the additional layers of support that we have to add is very different. Okay. And again, another big aspect of this too that I think we have to think about is breast augmentation is extremely safe, extremely effective surgery, and so is breast reconstruction, but the complications that we see are different. And one of those big complications that can happen after a mastectomy is
an infection,
skin necrosis and infection, right? And so we see this, and skin necrosis means basically the death of some of the skin that remains. Typically because when you take the breast out, the blood supply to the skin is no longer the same as it was before. And in those first 2 weeks, it really struggles to survive. Most of the time, all of it survives, but in a lot of patients, you can lose a little bit of additional skin after the mastectomy because the breast and the skin that remains is still trying to accommodate.
And that means that the implant must come out of your body, correct?
Not necessarily. It often means, again, if you catch the skin necrosis and it's not infected and you can simply cut it out and revise the skin, you can still cut it out and treat it before it becomes an infection. Okay, that's what we try to do in our practice.
And I will say it is frustrating as a breast cancer survivor when I hear people say, "Oh, it's just, you're just getting a breast augmentation." I'm like, no. And I will be very candid with you. You don't always look the same. No. There are some flaws because there's that tissue that is missing. I also had to wear expanders for a couple of months. I was very fortunate. I didn't have to wear them for a very long time. And by the way, I will say they're extremely hard. Okay,
they're not the most comfortable. That's
true. They feel like rocks on your chest. That is the best way to describe it. I then unfortunately had to take more chemo. I had to go to some chemo pills, so I got them removed. But a lot of times women have to wear expanders. I was very, very frustrated with the expanders portion when I got to my journey because I just kind of wanted to go straight into implants. Is that an option for some? And can you explain what expanders are?
So expanders are kind of like a temporary implant. They're basically, it's a device that has something in it called a port. And that port is the way that we actually fill the expander, okay? And the difference with the expander is that after surgery, you can access that port through the skin with a little needle to fill it with saline or fluid, okay? And that allows the expander to kind of grow in size until the patient tells us that they're at the desired size that they want to be for their anatomy.
But what if you don't want to be bigger than what you already are?
Yeah, so it's a great question. And I would say, my practice has kind of gone back and forth. In the past, direct-to-implant reconstruction, which is where you put the implant at the time of surgery, was actually more common than it is now. And I'll tell you why.
Why?
Okay, I tell this to a lot of my patients. So when you take out the mastectomy, right? You do the mastectomy, you take out the breast, the skin is threatened to survive, right? Those first 2 weeks are critical. any added pressure that you put on the skin at that time is going to potentially increase the risk of more death of skin or skin necrosis. Okay. So the reason we like to put an expander up front is because it allows us to kind of keep that partially deflated, not put any added tension whatsoever on the skin, and allow it to recover before we try to get you up to size.
So it's a healing thing.
It's a healing thing. That's primarily the thing. The second thing is, in the past, fat transfer, which is where you take fat from other parts of the body, wasn't as common as it is today. Today, essentially, all of our patients get fat transfer as a secondary procedure, regardless of what they have first. And so for those patients, because they're coming back to get that fat transfer regardless, we like to be able to use that procedure to adjust everything, put things exactly where we want it, et cetera. And so there's very little added benefit of putting the implant first, because again, I think I'm increasing the risk of skin necrosis possibility, okay? And I think I'm potentially I'm going back for that secondary procedure regardless. And then we also see that in patients who end up getting radiation, if you have an expander up front first, those patients then give us a chance to revise and treat the capsule and all those things secondarily, where they're less likely to develop something called capsular contracture. Okay. So for those reasons, I still often prefer doing the expander first, except for a couple scenarios. Typically, patients are either international or they really don't want expanders. And the other thing that I think are tricky with putting implants first is that you have to be willing to accept
what you get,
whatever size you get, right? There's no adjustment. There's very little adjustment that you can do, right? So if you then have an implant and then you end up needing radiation, which you often don't find out until after the mastectomy, if you now want to go significantly bigger, you may not be able to do so without having to change that out, put an implant or put an expander back in, and you're very limited by that. So for those reasons, I typically don't go to implant first, even though you can from a technical standpoint.
But is there a possibility that the patient might not have any other tissue to work with?
In terms of what you mean, like other from the abdomen?
from their abs or from any other part of their body. What do you do at that moment?
So I mean, for the vast majority of those patients, they're getting implant reconstruction regardless. So that's not something that I worry about too much, because again, we're so successful with implant reconstruction that essentially any patient that walks through my door, I can reconstruct them with implants.
Okay.
I'm just saying that in terms of doing the direct-to-implant reconstruction, I typically don't recommend it unless the patient is pushing me for it, because in the past, it sounded great. We're doing direct implant reconstruction. But again, I find that our outcomes are better. They look better. And it gives us that chance for that fat grafting anyways that we're doing for essentially all of our patients. Yeah. Plus, it doesn't put that added pressure on the skin. So
let's go back to expanders really quick, the air and saline. Which ones do you use? And is it just whatever you feel right for that patient?
Sure. So typically, I think this is kind of a misconception, because in the past, for some time, we had air expanders. They were kind of on the, I wouldn't say fringes, but they weren't as commonly. That's what I use, by the way. Right, and they were around. They're technically not in common. They're not used anymore. Partly because I think the company had to, the company went bankrupt or something else happened, so they're not available anymore in the U.S. Actually.
Gotcha.
It's not that they weren't safe. They worked fine. They just weren't as commonly used. Basically, it's just what you fill an expander with, whether you fill it with saline or air. Some patients, some doctors will temporarily fill it with with air before they switch to saline, which is the fluid. But the vast majority of us use fluid. And basically you have to access it with a little needle and fill it in the office, usually in weekly intervals, once your skin has healed enough to do so.
Okay, so once I was done with my implant surgery, I got them done, I got them removed. I kind of felt like, okay, I've moved on. I can now close this chapter of my life. Yeah. And then I hit a bump in the road. Yep. There was a recall with the implants that I had. Yep. And I really felt uncomfortable. And my doctor at the time, which is not you, advised me, you're fine. There's a very small percentage that something might happen, but I really just felt uncomfortable. Sure. But after everything that I've been through, why would I put myself in a position again where I could get cancer or something could happen that's wrong? I don't want to go back there and open that chapter again. How common is that for implants to be recalled? It happened to me. So how common is that, and should someone be aware of their implant bursting also at any point after they're done?
So to be honest, fortunately, the recalls are not very common at all. Okay. And when they do happen, there's usually nothing urgent about it, meaning you have plenty of time to get this done. Because you're a breast cancer patient, insurance is always going to recover going back, revising whatever needs to be done. Because again, it's a reconstructive patient. You're not a cosmetic patient. Okay. And again, the most important thing is there's no urgency. Similar to this, goes along the lines of the other two things that patients can get. One of them is capsular contracture, or the other one is implant rupture, right? I tell this to all my patients. Implants are not lifelong devices. They usually last for quite a bit of time, but every so often you eventually have to go in and change them out for something, right? And those things, when they happen, there's not an urgency to them. It's not threatening your health. It's not causing any other problems. It just means that you may have some discomfort, or the implants have moved, or you've noticed something, and we're going to go in and fix that for you.
It doesn't turn into any other complications if you have a rupture?
If you have a rupture, typically not, because these days we have, we're like in a 5th generation of implant gels at this point. And essentially, even if you slice the implant in half and you try to squeeze out the gel, they're cohesive. So they kind of stick out. And then once you let it go, it kind of ricochets back in.
Gotcha.
And remember, the breast, every time you put a breast implant in the body, or any implant in the body forms around it something called a capsule. That's a natural response to any foreign device in the body. When you have an implant rupture, the silicone that stays is essentially the vast majority of the time staying right there. It's still contained in that capsule. So what we typically do is we go in, we take out the capsule. If the capsule is hardened or causing some other discomfort, we switch the implant out and we put a new implant back in, and you get on with your life. And it's typically pretty routine outpatient surgery.
So during my journey, I was really focused on the chemo.
Okay.
I for some reason, I was just very, very scared of that first part. I really wasn't thinking so much about the reconstruction and the double mastectomy. I was kind of like, it's fine. Like, it doesn't matter. Like, I just kind of like wanted to move on. I think I was a little bit like in denial and trying to just like protect my emotional state while I had 3 young kids at the time. And I was like, what am I going to look like? Right. It was an emotional roller coaster. That is the best way I can describe it to you. How do you deal with your patients and that emotional side? Yeah. Because I know that when we walk in there sometimes, you're talking and it's like, I cannot hear a word. I remember sitting next to my husband saying, did you understand anything? Yeah. I'm an educated woman, and I swear to you, it just went right over my head.
So I think the biggest piece of advice that you've just given all of our patients, which I tell every single one of my patients, try to bring somebody with you to the visit. Right. Because no matter what I tell you, you're not going to remember 90% of it. And so it's important to have somebody with you, whether it's a friend, family member, husband, whatever, spouse, it doesn't really matter. But somebody who's going to sit there and actually hear what we're saying and listen. Somebody who's going to write, maybe write some stuff down or come with a prepared list of questions, because for you, you're going through, the visit with me, you're going with the visit with a breast surgeon, you're going with a visit, maybe a radiation oncologist or a medical oncologist or your primary care doctor. There's so many visits that happen so quickly right before you start treatment that it's very hard to process any of that information.
It is.
And for us, we do breast reconstruction on a daily basis. So for us, this is routine information.
And you see so many patients, right?
And so it's important for you to sometimes, try to take a step back, try to listen, try to understand. And I wouldn't focus so much on the details, right? As long as you have a good relationship with your plastic surgeon, I think they're going to guide you and give you the information that you really need to know. Mm-hmm. You can really get lost in the weeds otherwise, but try to take a step back and just listen and understand what the big picture options are and how you think you want to go about. And plenty of times it requires a second visit with us before surgery to say, look, just take the big picture information, think about what you want, maybe get some more questions written down, and then we'll have a follow-up conversation before we have surgery so that you can choose wisely as to what you think is going to be best for you.
Have you seen a lot of patients bounce back and get their self-confidence up a little bit?
After surgery?
Yeah.
Absolutely. Because I think, again, being able to wake up and not feel like you've completely lost, both of your breasts is a big deal, right? It's a big deal for self-esteem, for preservation of anatomy, all of those things. And cancer is already such a difficult journey that anything we can give these patients to maintain their identity and their sense of self as they go through it, I think is very empowering for patients.
Yeah. How common are revisions? I've already had 2.
Yeah.
3 maybe?
Sure.
How common is that?
So I think one of those, again, not as there's still revision, but at least partly one of those is due to recall. I tell my patients for sure, everybody is going to have, again, a vast majority of people, unless you go into direct-to-implant reconstruction, you might as well assume you're having 2 surgeries. The one where we put the expander and the second one where we take the expander out and put in the implant and do fat grafting and touch it up, adjust the pocket, make it look, as beautiful as possible. That's the second surgery. After that, I tell all my patients at some point in the next, whether it's 10, 15, 20 years, you're going to have at least one more surgery every so often. It could be 6 years. It could be 20 years. It could be 22 years. It varies, right? But you at some point will have something else. And the two primary reasons why that happens is either, again, implant rupture at some point, or you have capsular contracture, right? Which can happen.
I've had it.
And the capsular contracture is, again, where that capsule around the implant can kind of harden or distort the implant or cause some sort of discomfort, which we go in and treat it, right? A fewer percentage of our patients do eventually lose an implant from an infection or something of the sort. That can happen, right?
That's very scary when you hear infection as a patient, because you automatically think I'm going to lose what I have, which it's already hanging by a thread, as they say.
I would say, although it sounds terrifying for the patient, from our standpoint, even when we have an infection, we're typically, the vast majority of the time, we're able to salvage the reconstruction. Sometimes it does mean that you have to have the expander, removed for a little bit of time and then put back in, or the implant removed or put back in. Or sometimes it just means that we can treat with, washing and antibiotics and things like that.
And
it's
being
really
on antibiotics for a while,
case by case basis. But a large percentage of those patients are able to get their, reconstruction salvaged.
Isn't it just easier to go flat then? When you think about it, when you're like, all these steps that we have to do it. I know it's a very personal choice, but now I'll go back to just chemo really quickly. Yeah. If you decide to go flat, do you have to do chemotherapy?
If you, again, getting chemo has nothing to do with going flat or not.
Okay.
It simply has to do with what cancer's been taken out, what they find inside the breast, what they find, what they find elsewhere in the like the lymph nodes, for example. Those are the things that they're going to look at from a big picture standpoint, figure out your staging, your type of cancer, whether it's receptive, all those things. And the medical oncologist and the surgical oncologist, et cetera, will all team up together, and they'll make a decision as to what is best moving forward after that.
Okay. So if you decide to go flat though, it's just, what does life look like after that?
So life looks like, basically you have, some scars on your chest. And again, when you go flat, we try to preserve whatever bit of mound of tissue we have, but often there's not much. And even patients that can go flat, sometimes they have, essentially a concave chest, right? So the options moving forward are, you can use what's called an external prosthesis, which is, imagine like an implant that's kind of inside of a bra, right? You put it on the outside of your body, but underneath your clothing. And it gives you, underneath clothing, it looks like you have breasts on, when you have clothing on. The tricky thing that I think about going flat is there's always a percentage of our patients who need radiation after surgery, okay? Let's say 10, 20, whatever that percentage is. It's on a case-by-case basis, depending on your type of tumor. If you need radiation and your skin is radiated and you're already flat, putting in an expander or doing anything in terms of reconstruction after that is much higher risk than doing something up front.
Okay.
Right? So that's the one caveat to that I tell patients, if you're between the two, I would always err on the side of putting something in, like an expander, to preserve the skin. And if you choose in the future, you want to go flat and you want to take that out, nobody's going to tell you no. That's okay. It's your right.
Have you seen women have implants for a couple of years, do revisions, go through that journey and all that process, and then say, you know what, I'm done. I'm going flat?
It happens sometimes. It's not that common, but certainly a percentage of times that happens. And I think sometimes it happens. The more common scenario that I see is, patients maybe had breast cancer in their 40s or their, early 50s. They had breast reconstruction, they had breast, they had implants. Maybe they had, a revision or two in the next 10, 20 years. And then, sometimes when they're getting into their 60s or 70s, they're like, I don't even want to think about this anymore. Yeah. And they take them on, they move on with their life. And that's completely well within, it's their choice, and we're here to support them in whatever way possible.
It's kind of like what you said. You're like, every case is different. Yeah. This is like not one size fits all approach. And I'm assuming that you as a doctor, you're like, I'm going to try to find everything that I can, whatever way works, that's going to be the best, but also that you feel right moving forward, because obviously we're the ones that are walking out and having to deal with this every minute of the day.
Yeah, absolutely.
Yeah. And it's really like something that I think doctors are aware of the emotional, but also like the physical part of it. Science has changed a lot. Yeah. Also, I feel like when I got surgery in 2017 to like now, when I speak to so many women that are going through cancer and that have called me, I'm like, oh, I haven't even heard of that, or what is it, or that's different, that's new. How grateful are you for science and the fact that it has evolved to make it a little bit easier for you?
I think it's great. I mean, I think we as plastic surgeons, and so are the breast surgeons, we're always kind of trying to find ways to push the envelope, to continue to innovate and to continue to find ways to make the recovery, not just the recovery, but also the outcomes that we have better. I think one of those things that we're doing now that we didn't do in the past is nerve reconstruction for some patients.
Yeah,
right?
that's actually very new. That wasn't an option for me,
Right.
but I hear it's women are loving it. The
Right.
fact that they get to feel
Right.
a little bit of sensation.
Correct. Yeah, I think, in the past, similar to how we talk about the blood supply, where when you take out the breast,
Yeah.
the blood supply to the skin, a lot of that blood supply goes with that. And so that's why you're at risk at losing skin. Every time you cut through that breast, you also are cutting through the nerves that feed the skin and allow the skin to actually feel, right? Sensation. And a lot of patients who don't undergo nerve reconstruction, and again, right now there's only a few certain patients that are candidates for it, but
Right.
those that don't undergo reconstruction, the rest of their breast feels numb, right? It feels kind of asleep, and that's permanent, right? You can regain some sensation kind of in the periphery of the breast, but the central breast really remains numb for the rest of your life.
Yeah, or you feel like a nerve, like something tingling,
Right.
and
You
you're like,
sometimes
"Whoa, what
feel
was
these
that?"
twinges
Like
and
a little
stuff.
something, yeah.
But nerve reconstruction for some of the patients, primarily the nipple-sparing mastectomy patients, allows us now to try to find some of the nerves that are, again, would have otherwise traveled through the breast, preserve them, and reconstruct them to connect them so that hopefully in the next 6 months to a year, some of that sensation comes back. And we're starting to learn more about that process and really understand how much of those patients are regaining and stuff. It takes time.
Yeah, of course.
But it's an exciting evolution that I think is going to continue to spread.
Is there one thing that you're keeping an eye on that you're like, oh, this is going to be great for my field?
I mean, I think that's the one that the biggest thing right now, I'd say, is nerve reconstruction, to be honest. Other things that continue to evolve are simply, how do we perform breast reconstructions that are safer, that allow minimizing rates of capsular contracture, for example. Obviously, all the implant companies are always trying to innovate and finding ways of minimizing rupture and things like that give us better outcomes, right? Because if you don't have a rupture, you're less likely to need an implant revision, for example. And so all those little things on multiple fronts, I think will continue to give breast cancer patients better outcomes in the years ahead.
Can I add one thing that I would like?
Yeah, please.
Maybe put it out there in the universe so someone can hear. Implants with no ripples. How's
no
that?
ripples, yeah.
That would be a good one.
Work
right?
in progress.
That's a work in progress.
They've
but
definitely
you know what?
made adjustments, but they're not completely gone, for sure.
They're not, but that's okay.
But I think, to your point, right? I think one of the reasons fat grafting is so critical and it's so helpful is because it helps to add another layer of soft tissue on top of the implant so that we can minimize our ripples.
But this is when being a thin human doesn't really help you.
In that sense.
It's not beneficial, Dr. Mattos.
Yeah.
I'll be very honest with you.
I
It just doesn't work sometimes for everyone.
Yeah,
so
it does not.
So you have to live with the ripples. And you know what? I will live with it because I'm healthy right now. And that's what counts.
Yeah,
exactly. Thank you so much for allowing me to share my story and for also kind of giving us all your insight, your expertise. This was a really wonderful conversation. Thank you so much for being here. And remember, to our viewers, be sure to hit that subscribe button on our channel here to keep up with the latest health and wellness information and tips from our experts. Thanks for watching.
Find additional valuable health and wellness information on our resource blog at baptisthealth.net/news. And be sure to interact with us on our social media channels for live and upcoming events. Baptist Health Talk is brought to you by Baptist Health, the warmer side of care.